Hi guys. So in today's lecture we will discuss heart sounds. This is a very important lecture on a very important topic. But had this not been a medical lecture, it would have been a very romantic one. But being a discussion on medical aspects of heart sounds, you guys will at least require a stethoscope to interpret it. However, in real life you can hear heart sounds with help of naked ear itself. Okay, so let's start. Right. So in order to hear the heart sounds, you guys will need to auscultate the heart. In general, we study the first two heart sounds, that is S1 and S2. But in this particular lecture, we will also take up other physiological and pathological heart sounds, for example, S3 and S4. Okay. Before proceeding ahead, let's discuss auscultation areas of heart. So basically, there are five auscultation areas of heart which can be remembered with the help of mnemonic. All people enjoy Time magazine, and you can very well appreciate that only aortic area is situated towards the right side of sternum. All other areas are situated towards the left side of sternum. So let's see. All people enjoy Time magazine. I have already stated that only aortic area is situated towards the right of sternum. But what is the exact place? Let's see. Aortic area is situated in the second intercostal space towards the right of sternum, just at the parasternal position. Okay, this is situated towards the right of sternum. This particular thing is aortic area, followed by pulmonary area. Pulmonary area is also situated in the second intercostal space, but this is towards the left of sternum. Okay, then you have Erb's point. This Erb's point is situated in third intercostal space, right? All areas apart from aortic area is situated in the left side of sternum. Okay, just in the parasternal area you have Erb's point in third intercostal space. The relevance of this Erb's point is that murmur of majority of conditions like HOCM, VSD, even splitting of second heart sound can be better appreciated at this point. Okay, then you have tricuspid area situated in fourth intercostal space, left side, just in the parasternal region. Last, you have mitral area. This is situated in fifth intercostal space, but this is not in the parasternal region. This is situated in the mid clavicular line, and this mitral area corresponds to apex. Okay, so these are various auscultation areas of heart. Right, let's have a look at the cardiac valves. So you guys very well know that there are four cardiac valves. You have mitral and tricuspid valves as atrioventricular valves. You have pulmonary and aortic valves as semilunar valves. See, this mitral valve and tricuspid valve will close together and give rise to first heart sound, that is Lubb. Similarly, aortic valve plus pulmonary valve will close simultaneously and give rise to second heart sound, that is dub. Okay, now one thing has to be understood. Normal heart sounds are only produced due to closure of valves, not due to opening of valves. Okay, so S1, that is Lubb, that is first heart sound, will get produced with the help of simultaneous closure of mitral and tricuspid. On the other hand, S2, that is second heart sound, will be produced due to simultaneous closure of semilunar valves, that is aortic and pulmonary. There are two other heart sounds, that is S3 and S4. S3 is mainly pathological, but sometimes it can be physiological as well, whereas S4 is always pathological. So you have S1, you have S2, you have S3, you have S4. We will discuss each of them in detail. These are normal heart sounds, these are high pitched. These are abnormal heart sounds in general, these are low pitched. Okay, these high pitched sounds are better appreciated by the diaphragm of stethoscope. These low pitched sounds are better appreciated by the bell of stethoscope because diaphragm filters out low pitched sounds. Okay. Now let's see one more thing in general. You have S1, that is first heart sound produced due to simultaneous closure of mitral and tricuspid valves, at the initiation of systole. The first part of systole is isovolumetric contraction. Due to this, pressure in ventricles rise and mitral and aortic walls close. That is, their flaps hit against each other like you close a door. So S1 is caused by M1 and T1. Okay, that is simultaneous closure of atrioventricular walls, followed by S2. When ventricles are done with contraction, even your semilunar walls close, aortic as well as pulmonary, resulting into second heart sound. So we were discussing initiation to end of systole. So this period has to be systole. And you guys know that after systole in a cardiac cycle, you have diastole, which is longer than systole. So you have again S1, that is initiation of the next systole, and again S2, that is end of the next systole. So this is again your systole, whereas this is your diastole. So in normal scenarios, you have two heart sounds, that is S1 and S2, and the period between S1 and S2 is systole, whereas the period between S2 and S1 is diastole. Now I am going to add two more sounds. Okay, let's see. You have S1, you have S2, you have again S1, you have again S2. Okay, this period is your systole, this period is your diastole. Okay, so in serial order, we have already discussed S1 and S2. So the next thing should be S3, and the next thing should be S4. So you can very well appreciate that I have added two more sounds, right, during the phase of diastole as per serial order. S1, S2, S3 and S4 can be added serially only after S2. So these two are diastolic sounds. S3 can be physiological or pathological, S4 is always pathological. So this is your S3 and S4. These are your diastolic sounds, but mostly these are not normal. Okay, sometimes you can find all four sounds all together. This is known as quadruple rhythm. Okay, we will discuss all these things in later part of lecture. So till now you have understood that there are four heart sounds: S1, S2, S3 can be physiological or pathological, whereas S4 is always pathological. Plus S3 and S4 are diastolic sounds, plus they are low pitch sounds, so they have to be better heard with help of bell of stethoscope. Okay, right. Let's have basic understanding of cardiac cycle as well. You guys know that average heart rate of adult person is almost 72 beats per minute. So one cardiac cycle, that is one heartbeat, will be of what? One cardiac cycle or one heartbeat will approximately be of zero point 0.8 seconds. Too simple to understand. I am just trying to say that ventricular diastole will be bigger, ventricular systole will be smaller. Same will apply for atrial events as well. So cardiac cycle is of zero point 0.8 second, right? You have atrial events as well as ventricle events. Atria will also contract and relax, right? So you have systole, you have diastole. Ventricle will also contract and relax. In general, systole, you mean ventricular systole, okay? So this has systole, this has diastole. This is of zero point 0.1 second, this is of 0.7 second, this is of 0.3 second, this is of 0.5 second. So this has to be understood, okay? We will apply this knowledge in upcoming part of slides. Let's see. You have S1, you have S2, and you have again S1. Okay, I have intentionally written S2 as A2P2 because even in physiological conditions, sometimes you can appreciate A2 discretely and P2 discretely. Okay, particularly during inspiration. So you have S1, S2, this is your systole. This is smaller, only 0.3 second, whereas this particular thing is your diastole. This is longer, this is of zero point 0.5 seconds. Okay, and majority of abnormal heart sounds will lie in this longer period of diastole. Okay, see here you can easily appreciate S3, S4. Later on I will introduce two more heart sounds, that is ejection click and opening snap, but as of now I am not discussing them because they are being discussed in later part of lecture. See, you have S1 and S2 in normal scenarios, okay, and this has to be your systole. And then you have diastole, again you will find S1 and S2, okay. So systole, systole, and this particular period is diastole. I am simply adding two more sounds serial wise. Okay. So this diastole is longer and it will accommodate two more sounds which are mostly abnormal. So you have S1, you have S2, again followed by S1 and S2, and this is diastole. So serially you can add two more sounds. One is your S3, one is your S4. We already know that S1 is due to simultaneous closure of atrioventricular valves. S2 is due to simultaneous closure of semilunar valves. And these two additional diastolic sounds must be produced during ventricular filling. But what are the phases of ventricular filling which can lead to production of S3 and S4? Before we discuss S3 and S4 in detail, let's have a basic understanding, okay? S3 is basically produced during rapid, passive filling of ventricles, whereas S4 is due to forceful atrial contraction. How to understand these things? This is again very easy. Let's have basic understanding of ventricular filling that happens in diastole. See, ventricular filling is not a single phase phenomena. There are three phases: rapid phase, slow phase, and then active phase. Let's try to understand this particular thing because this will help us understand about the S3 and S4. Okay. See, ventricular filling. Suppose I draw this diagram S1, S2. Followed by S2, you will again find S1 and S2. So this is your systole. This is again your systole. But this particular part is your diastole. When you will find what? S3 and S4 is present. So here you can have S3 and here you can have S4. But as of now, I am not marking S3 and S4. I am just trying to give you a fair amount of idea regarding ventricular diastole and genesis of S3 and S4. See, ventricular filling is happening in three phases. What are these three phases? First is rapid passive, second is slow passive, that is diastasis, third is active filling, that is due to atrial contraction. So ventricular filling is happening in three phases. In the first phase, whatever blood is collected in the atria will open the valves, that is atrioventricular valves, and will rapidly rush into ventricles. And later on, this pressure difference will decrease, and there will be slow passive filling of the ventricles, also known as diastasis. And then finally, the last one third of the blood will be pumped actively by the atria. Try to understand this particular part, this particular part, this particular part are different. This is responsible for one third of filling of ventricles. This is again for the next one third. This is again for the next one third. So ventricular filling is being taken by three parts. Okay, let's see. This is rapid passive filling. This is slow passive. This particular thing is also known as diastasis. Okay, last but not the least, the rest of one third blood will be provided by active, and this active process will be atrial contraction. Atrial contraction. Too simple to understand. See, now you can relate. This slow filling cannot lead to that turbulence or vibration to produce a sound. This can produce a sound, so this can be S3, this can be S4. So we have studied that S3 and S4 are in serial order. So S3 comes first, S4 comes later, and this cannot produce sound, that is slow passive filling, that is diastasis. So S3 has to be due to rapid passive filling, whereas S4 has to be due to what? Active atrial contraction, whenever atria will require to contract against a greater resistance. Okay, let's see. You have S1, you have S2, and now I am writing S3 and S4 as well. So this has to be your systole. This particular period will be your diastole, right? Followed by what? Next systole. Okay, something like this. Now this is pretty clear. This is systole, this is diastole, this is again systole. So how these sounds are getting produced? S1 we have studied many times due to closure of mitral and tricuspid valves. S2 is being produced due to closure of aortic and pulmonary valves, whereas S3 is getting produced due to sometimes physiologically, sometimes pathologically, we will discuss, due to rapid passive filling. Rapid passive filling, right? And S4 will be due to atrial contraction. Suppose someone is suffering from mitral stenosis. To overcome this stenosis obstruction, atria will have to contract forcefully. And this forceful contraction of atria can lead to turbulence and producing S4, something like this. So now you have basic understanding of genesis of all these four heart sounds. Once again, I will like to repeat that S3 can be physiological or pathological. S4 is always pathological, and S1 and S2 you guys know that they are normal heart sounds. So S1 due to closure of tricuspid and mitral valves, S2 due to closure of aortic and pulmonary valves, S3 due to rapid filling, and S4 is due to, if present, it is due to forceful atrial contraction against stiff ventricles, particularly seen in where hypertension, HOCM, okay, aortic stenosis, etc. We will discuss. Right. Now let's discuss the first heart sound in detail. Okay, we have already discussed basic thing. Now let's discuss in detail. So first heart sound S1 is produced due to simultaneous closure of mitral and tricuspid valves. Okay, so this has two components, but they are too close to differentiate. So normally you don't find any splitting of first heart sound. Okay, this is popularly known as Lubb. Okay, and I have already mentioned that S1 and S2 will be better appreciated with help of diaphragm, whereas S3 and S4 will be better appreciated with the help of bell of stethoscope. Okay, so this is very simple. Now question arises, sometimes you get pathological S1 in form of either loud S1 or soft S1. So we will need to develop some concepts how to study, how to memorize causes of loud S1 and soft S1. Have a look at this question. The first heart sound is loud in all of the following except. You have options in form of mitral stenosis, short PR interval, tachycardia, mitral valve calcification. Before jumping on to the causes of loud and soft S1, let's develop a simple approach. You have loud S1, you have soft S1. Okay, loud S1. You guys know that S1 is produced due to hitting of the flaps of atrioventricular valves. In case these flaps hit at a very fast rate, they will produce more sound. That will lead to what? Louder S1. And if these flaps hit at a very slow rate, they will produce softer S1. Okay. So in cases of hyperkinetic circulation, hyperdynamic circulation, whenever heart rate will be high, there will be loud S1. And heart rate and PR interval are inversely related. So if PR interval in ECG will decrease, heart rate will increase. So these will result into loud S1. Apart from this, suppose someone is suffering from valvular disorder by the name of mitral stenosis. In mitral stenosis, to overcome this stenosis, atria will have to contract with greater force. This will result into what? Faster and forceful opening of mitral valves and forceful recoil as well. Okay, so in case of mitral stenosis also, you guys will get what? Loud S1. So second has to be your mitral stenosis. Reverse will apply to the cases of soft S1. So if ever heart rate will decrease, bradycardia might be due to heart block. Suppose in case of mitral regurgitation, so mitral regurgitation will be anyway opposite to what? Mitral stenosis. So this is very simple question. But in case of mitral stenosis, sometimes in later stages the walls get calcified. A calcified wall cannot move as fast as a normal wall or stenosed wall can. Okay. So whenever there will be calcification, be it mitral wall, aortic wall, pulmonary wall, their mobility will be limited, right? So they will lead to production of softer sounds. Okay. So answer over here should be mitral wall calcification. Let's see. You have loud S1, you have soft S1, and causes of loud S1 now can be fully understood. It can happen due to mitral stenosis on the left side, whereas it can be due to tricuspid stenosis on the right side. Okay. Other examples in which heart rate will increase: hyperdynamic circulation, hyperkinetic circulation. For example, someone suffering from thyrotoxicosis, pheochromocytoma, right? Something like this. So this has become now very easy. In even thin individuals, you can appreciate loud S1. Okay. So here, in case of soft S1, you can easily relate to this thing as well. Soft S1, when walls will hit each other, but not at a very fast rate. Okay. So opposite of mitral stenosis and tricuspid stenosis, you have mitral regurgitation, tricuspid regurgitation, and opposite of tachycardia, you have bradycardia. This might happen due to any reason, be it bundle branch block, be it first degree heart block, be it third degree heart block. Simply write over here heart blocks. So now you can easily understand causes of loud S1, causes of soft S1. Be it loud S1, loud S2, or each and every heart sound will get diminished if there is any obstruction to the travel of sound. For example, someone is suffering from emphysema, right? Lungs will obstruct, lungs will inflate the chest. So sound will have to travel a greater distance, and this sound will slowly perish, resulting into softer appreciation of sounds through the stethoscope. So in case of obesity, again chest wall diameter increases. In case of emphysema or in case of pericardial effusion, there will be hindrance, right? And the sound will have to travel for a longer distance. So intensity of sound when it will reach the chest will decrease. So in all these cases, you will get soft S1 or soft S2. We will discuss soft S2 in upcoming part of the lecture. Okay, so this has to be also understood. If there is any obstruction or if the sound has to travel a longer distance before reaching the chest, then the intensity of sound will decrease. Okay. So now let's evaluate this question. The first heart sound is loud in all of the following except. You have first option in form of mitral stenosis. We have already discussed that in mitral stenosis, forceful opening of wall will lead to forceful recoil as well, resulting into loud S1. Short PR interval will again lead to tachycardia, and tachycardia is one of the common causes of loud S1. Whereas you have mitral wall calcification. Though mitral wall calcification is more or less equivalent to mitral stenosis, okay, I will like to tell you guys that in later stages, mitral stenosis, the wall gets calcified. So you have calcified mitral wall and you will have calcified mitral stenosis. Calcified walls cannot move much. Okay, so they will not hit each other at a fast rate. Okay, so in case of calcified mitral stenosis or in case of calcified aortic stenosis, pulmonary stenosis, the wall mobility will get limited, resulting into softer sounds. Here we are discussing S1, and later on we will discuss soft S2 due to stenosed, calcified pulmonary walls and aortic walls. Okay, so answer here has to be mitral wall calcification. This will lead to soft S1, not loud S1. Okay. Now let's discuss second heart sound, that is S2, that is dub. We have already studied that this is getting produced due to simultaneous closure of aortic and pulmonary valves. Okay, this will lead to second heart sound, that is S2, that is dub. This is again high frequency sound, will be better heard by diaphragm. Okay, better heard by diaphragm. Now let's have basic understanding of splitting, particularly of second heart sound. Here you can appreciate that S1 is not splitted. S1 has two components, M1 and T1. but they are close enough. They cannot be physiologically split. Now you have S2 in form of aortic component, that is A2, and then you have P2. Alphabetically also you can write A2 P2. This is normal. Okay, A2 has to come first. Left sided cardiac events happen first. Okay, so A2 followed by P2 is normal, and normally the gap between them is only up to 30 milliseconds, which cannot be appreciated by your ear. Okay, so in cases of normal S2, during expiration, the gap between A2 and P2 is only 30 milliseconds. However, this gap between A2 and P2 increases during inspiration, right? And this increases up to 30 to 45 milliseconds. Now this can be appreciated. Okay, this is known as physiological splitting. Physiological splitting of second heart sound during inspiration. Why this splitting occurs during inspiration? See, P2 got delayed. This is a common sense. During inspiration, venous return increases. So blood flow towards the right side of heart increases, resulting into delayed closure of pulmonary walls, resulting into delayed P2. Too simple to understand. But this physiological splitting is considered normal. However, sometimes this duration is increased even in case of expiration. That is known as wide splitting of second heart sound. Sometimes this duration decreases. That is known as narrow splitting. Sometimes reverse of this can happen. That is P2 comes first and A2 comes later. That is paradoxical splitting or reverse splitting. We will understand each and everything with simple logic. No need to remember a lot of big charts. Okay, let's see. Now let's discuss little bit about loud S2 and soft S2. See, loud S2 can be divided into loud A2 or loud P2. Okay. Similarly, you can have soft S2 which can be divided into soft P2 or soft A2. We have already discussed that in case of mitral stenosis and tricuspid stenosis, intensity of first heart sound increases. So you get loud S1. But by applying with this logic, you can conclude that in case of pulmonary stenosis and aortic stenosis, there should be loud A2 or P2. But that is not the case. In case of pulmonary stenosis and aortic stenosis, in majority of conditions, there are calcification of valves, right? There is ample calcification right from the starting, whereas that is not the case in case of mitral and tricuspid valves. So when we will discuss mitral stenosis and tricuspid stenosis, we will say that there will be loud S1, whereas in case of pulmonary stenosis and aortic stenosis, there will be soft P2 and soft A2. When will this A2 and P2 get louder? See, in case of hypertension, aortic valves will close against a greater pressure. Similarly, in case of pulmonary hypertension, there will be greater pressure in the pulmonary arteries. So, pulmonary valves will again close against greater pressure. So, for loud A2, you have hypertension. For loud P2, you have pulmonary hypertension. Okay, for soft A2, you have aortic stenosis. For soft P2, you have pulmonary stenosis. Okay, so this is more than enough regarding loudness of second heart sound. Right, now let's again shift our focus towards the splitting of second heart sound, which is very important part of this lecture. We have already discussed that there can be physiological splitting. Physiological splitting of second heart sound. This has to be understood in form of A2 and P2 being heard distinctly. Okay, physiological splitting has to be appreciated during inspiration, because in inspiration venous return increases, so P2 closure is delayed in the same proportion, right? So A2 remains at its place whereas P2 shifts little longer. So there is a splitting. This gap is more than 30 millisecond and this can be appreciated easily, whereas splitting cannot be appreciated during expiration because this time gap is hardly 30 millisecond or less. Okay, so this is very simple. Now we will discuss pathological conditions in which splitting will increase, right? That will be appreciated in the expiration as well. And sometimes splitting can reverse. P2 component can come ahead of the A2 component, that is paradoxical or reverse splitting. Sometimes splitting will be variable, that is wide and variable. Sometimes the splitting will be wide and fixed. Okay, we will not mess up, we will discuss each and everything with concept, and ultimate result of our discussion will be a simplified version of splitting. Okay, let's see. See, here you can easily appreciate that if component A2 and P2 become away from each other, that is more than 30 milliseconds, this can result into splitting. Physiologically, this can happen during inspiration, right? So this is known as physiological splitting. Normally you have hardly gap of 30 milliseconds, but during inspiration A2 remains at its place, whereas P2 gets delayed due to increased venous return. There is more blood in the pulmonary circuit, resulting into delayed closure of the pulmonary valves, resulting into delayed P2. Too simple. But in few pathological conditions, even during expiration, you can have a gap of more than 30 milliseconds, resulting into splitting. And that gap will be further increased with inspiration. So that wide split will become variably more in case of inspiration. Let's see. Let's try to understand this with all these diagrams. See, in normal situation, S2, A2 and P2 are close enough. That is up to 30 milliseconds during expiration. But during inspiration, due to increased venous return, P2 gets slightly delayed. So you get physiological splitting, right? This has to be during inspiration. Whereas in certain cardiac conditions, there can be what? Early appearance of A2 and late appearance of P2, resulting into widening of the gap even during expiration. So this is wide split, and definitely this split can increase further during inspiration. So you can say that this is wide and variable split. That is, it varies with inspiration or it varies with expiration. In the second case, you have wide and variable split, whereas in the third case there is splitting, but respiration will not alter the splitting. See, in expiration also there is this much splitting, in expiration also the splitting is same, is splitting present, but it is wide and fixed. So you will need to remember two cases. In this, one is ASD, second is TAPVC, that is total anomalous pulmonary venous condition. See, in other cases, in few cases, sometime A2 can be very delayed and P2 can come very early. So there will be reverse splitting, right? That is known as paradoxical splitting, seen mainly in case of severe aortic stenosis. Okay, let's discuss again. During inspiration, naturally P2 gets delayed, so there is physiological splitting. In few cardiac conditions, there is wide splitting, that is, splitting can be appreciated even in expiration and that further increases during inspiration. Okay, so this is wide and variable, right? In third situation, I am talking that splitting is present even during expiration and it will be present even during inspiration, but it will not increase or decrease. Okay, so this is wide and fixed, that is no effect of inspiration. I will explain, and here you have to simply remember two causes. One is ASD, second is TAPVC. Okay, why there will be wide and fixed splitting, we will discuss. And in last case, you have paradoxical splitting. Just remember that in paradoxical splitting, P2 comes first, A2 comes later, right? So this is paradoxical splitting seen in case of severe aortic stenosis, in which aortic stenosis will lead to very delayed opening of aortic valve and it will also result into delayed closure. So in this process, P2 will come first as compared to A2, resulting into what? Resulting into paradoxical splitting, right? Now let's try to understand this thing in detail. Okay, for wide split you need either early appearance of A2 or delayed appearance of P2 or both. So this can happen due to early A2 or late P2. Late P2 can be understood very easily, right? Suppose there is pulmonary stenosis. Valves will open late and valves will close late, so P2 will be delayed. So here you can take example of pulmonary stenosis. Same will apply to pulmonary artery hypertension. Same will apply to right bundle branch block. So right side you have delayed impulse and therefore delayed closure of pulmonary valves. Opposite of this can be said with left ventricular pacing, right? Left ventricle will contract first and aortic valve will therefore open and close first. Plus there are other causes as well which we will figure out with our logic and discussion. Let's see. Right, and this splitting of second heart sound in detail. We are talking about wide split of second heart sound. To happen this, you have A2 and P2. P2 should be delayed, A2 can come early. For delayed P2, you have pulmonary stenosis, right bundle branch block, you have pulmonary hypertension. Okay? For A2 to come early, you have multiple things, but till now we have discussed only right ventricular pacing. What about other causes? Let's discuss. See, in case of mitral regurgitation, what actually happens is that majority of blood from left ventricle spills out into left atrium instead of going into the aorta. Therefore, flow through aorta will be decreased and aortic wall will close earlier. So this can again result into what? Early A2. Let's understand. Always make a habit of making line diagram. Let's see. Here we are going to discuss mitral regurgitation. In mitral regurgitation, when left ventricle will contract, some blood will go towards the aorta and some blood will spill into the left atrium. So here you have less of blood in aorta. So less blood in aorta will result into earlier closure of early A2, earlier closure of aortic valve. So in case of mitral regurgitation, because blood flow through left part of heart, through left side of heart decreases, that is blood flow through aorta decreases, resulting into early closure. Let's take another example. Let's take example of ASD and VSD in pediatrics. Okay, example atrial septal defect or ventricular septal defect. In case of atrial septal defect and ventricular septal defect, let's take both hand in hand. In case of atrial septal defect, blood from left atrium will leak into right atrium and it will ultimately travel to the pulmonary artery. In case of ventricular septal defect, blood from ventricles will leak into, that is left ventricle will leak into right ventricle and there will be more blood flow. Where? There will be more blood flow via pulmonary artery through pulmonary valve. Therefore, P2 will be delayed and delayed P2 will also result into what? Will also result into wide split. So this is again understood. Right. So let's summarize now. So for wide split, I'm not talking whether it is wide and fixed. I'm simply saying that you have MR, ASD, VSD, and then problems related to pulmonary circulation. I am intentionally leaving total anomalous pulmonary venous connection, but I will explain it in the later part of lecture. For narrow split, A2 has to come late and P2 has to come early. So by common sense, you can conclude that in narrow split, what will actually happen? A2 will be delayed or P2 will come early. So you don't need any diagram or any chart. This is very simple. A2 will be delayed if there is systemic hypertension, if there is aortic stenosis, or if there is left bundle branch block. This can happen due to aortic stenosis, left bundle branch block or hypertension. Too simple to understand. And P2 can come early in case of what? Right ventricular pacing. Okay, so these can cause what? Narrow split. See, what about paradoxical split? Paradoxical split can happen if aortic stenosis becomes severe and severe. Initially, A2 will be delayed, right? And split will narrow. Later on, A2 and P2 will come at same time. That will be single S2. Okay, and later on A2 can be delayed, even more delayed than the P2. Then you can find a reverse split of second heart sound. Let's understand two more. Right. So in this last part of the lecture, we will discuss why there is wide and fixed splitting in case of ASD and TAPVC rather than wide and variable. We have already discussed that during inspiration, venous return increases, resulting into delayed closure of pulmonary walls, that is delayed P2, resulting into wide and variable splitting. But in case of ASD and TAPVC, there will be no variation with respect to inspiration or expiration. Why? See, in case of ASD, there is already increased amount of blood coming into right atrium via left atrium. So, whether there is inspiration or expiration, blood will come from inferior vena cava and superior vena cava, but it will not significantly rise because already right atrium is filled with enough blood. It cannot accommodate any further. Right, so I hope you guys got my point. In case of atrial septal defect, there is already excess blood in the right atrium which has come from left atrium. Okay, so there is no scope of further increment of blood into the right atrium during inspiration. Right atrium is already full. So in case of ASD, right atrium gets blood from left atrium as well as from inferior vena cava and superior vena cava. This blood increases during inspiration and overfills the right atrium. But in case of ASD, there is no scope of further increment because that amount of blood has already been taken from the left atrium. Okay, so there will be wide splitting, but it will be fixed. It will not vary with respiration. Okay, right. Similar is the case with total anomalous pulmonary venous connection. As the name itself indicates that it is total anomalous pulmonary venous connection. And in this case, instead of this pulmonary vein opening into left atrium, it has opened into the right atrium. So again, right atrium is receiving blood from two inputs. One is your inferior vena cava and superior vena cava, and the other one is pulmonary vein. So again, there is no scope in the right atrium because it has limited capacity to accommodate any extra blood during inspiration. Okay, so in this case of TAPVC, you have again right atrium getting blood from two sources. One is your inferior vena cava and superior vena cava, and the other one is your pulmonary vein, right? So whatever blood right atrium would have accommodated more during inspiration, it has already been provided via the pulmonary vein. So there is no increment in blood in the right atrium during the inspiration. So there will be splitting, but it will be wide and fixed. So I hope you guys understood my point. So let's summarize. We have already studied physiological splitting of second heart sound, which is absolutely normal. We have studied wide and fixed splitting just before this slide. This is ASD and TAPVC. Apart from that, each and every cause which we had earlier studied, which was causing wide splitting, right? But it will not cause wide and fixed. Rather, it will cause wide and variable splitting. So first we have studied causes of wide splitting. Now we have segregated causes of wide and fixed splitting in form of ASD and TAPVC. So now we are left with only left ventricular pacing. Okay, then on the other hand you have pulmonary stenosis, pulmonary hypertension, left bundle branch block, etc. Okay, and what about narrow splitting? In narrow splitting we have already discussed that you can have what, you can have right ventricular pacing, left bundle branch blocks, you can have hypertension, right? You can have mitral regurgitation, etc. So this concludes our lecture on first heart sound, second heart sound, general discussion on heart sounds, and in second heart sound we have particularly discussed what, splitting in detail. Okay, so that's all. Bye bye.